causing is complication. And vertebral body fracture is one of the complication of osteoporosis. Although the commoner complaint would be a pain in the back or the pressure points for that matter, like knee and all. But if it is really causing fracture, that has to be addressed in time. I'll tell you, if you don't take it rightly at right time, what all it can cause, what all complications are there, we should really know it. And it's so easy to treat these days with the interventional technique that you don't have to go for that big surgery, which normally is contemplated for such patients earlier. Now that's not the case. It's like interventional cardiology. If somebody has got a cardiac problem, you can manage with the angiography and stenting instead of going for a big bypass. Same thing is in spine also. So we're going to talk about osteoporosis and its complications. Just take you a second. Yeah. Yes, my friends. So we're together. Now this we know is a disease of hollow bones. You see, this is what a normal bone would be like in any human being. This is cardio specimen, this is a disc there, this is the nucleus, this is annulus, and this is what a dirty or empty bone is like this. This is a hollow bone syndrome, we can call it, and even the disc is, you can say, degenerated in this patient. So when these hollow bones are there in the body, any pressure, when you put more than extra pressure than usual, it causes fracture. Normally it comes with the trivial trauma, like fall in the bathroom and all. This causes fracture, sometimes a accident or motor vehicle accidents. And but in older age with the severe osteoporosis, even picking half bucket of water or even sitting bang on the sofa can cause these kind of fractures. And people sometimes don't have the real history that why it caused fracture, and they're surprised by the fractures. But we know it by now that even a small trauma can cause fracture. It's like it's a simile. Like we used to say, hip fracture, hip neck is there because of the fall. Now we realize that the patient gets fracture first and falls then. So same situation happens in spine sometime. You have a trivial trauma and there is a fracture. Because with increasing age expectancy over a period of time, there are many people who are going to be 85 and over. Obviously 65 over is going to be a much commoner, which is the case in India too. As we are advancing into a new generation and newer era, so more and more people are living longer. Like in Japan, they're living approximately 90 to 100 years average age expectancy in all developed world. But remembering the fact, as you age, like the hairs go grey and the prostate gets enlarged, same way the bones get empty and they get this kind of problem coming. So we have to be ready for this kind of problem coming in older age people, and we have to address them. We can't leave old person, you cannot leave them alone, because they become very big liability for the whole family. So we have to treat them in time and let everybody be back to work. Now it is seen the commonest fracture in the vertebral body is the L1 fracture. The next common is the D12 and then is the L2 one. Because this is the area, D12 L1 is the area where there is a flexural angle, the flexion is there, dorsal lumbar flexion or angulation is there, and that takes the maximum load. And when people, because the ribs otherwise splint the dorsal vertebra, but the lumbar junction is more mobile, and that's where the whole load comes and they get fracture. Just because D12 L1 gets common fracture and there is a maximum flexural load there, they get worsen also for the same reason, because the loading and flexion. Now, if you don't treat them osteoporotic fractures, and especially if they are painful, then obviously it causes a lot of back pain, deformities, it decreased lung capacity because of the flexion or raised diaphragm for that matter, impaired functions are there, loss of appetite because the lower volume space for the stomach, sleeping problems, they can't turn in the bed, decreased activity will bring more and more sarcopenia, osteoporosis, further osteoporosis, and obviously more bone loss is there, increased fracture risk to the other level. Remember, there is one fracture, having chance of having another fracture is almost 5 times in normal population. If somebody's got 2 fracture, chance of having a third fracture is almost 100 times. So one has to be very careful on these accounts. That's why we try to treat them. We are not treating one fracture, remember. Once somebody's got a fracture, we have to treat all the bones together. That's the whole idea of doing this. And there is always an increased age related mortality in these subset of patients who've got osteoporotic bone fractures, especially vertebral fractures. Now they're really in pain. We got to do something for them. We want to help them. Sometimes even surgery is not good or great enough. I keep getting patients even out surgery. And we already know that pain is the 5th vital sign, and is already declared by the WHO and the UN that we really have to do help these patients, because it causes the chronification of pain or central sensitization pain. That shouldn't happen. A chronic pain is a different disease than just an acute pain, and then it's not just a peripheral pain, it becomes a central pain, and which is more difficult to treat. So that's why it is given all this importance. Yes, people keep giving painkiller. Patient takes painkillers. In India, it's very, very common that they go to the chemist shop, they ask for a painkiller. The chemist is very happy, it's business, and then they get all this kind of complication. Be it the gastric, we know the nephrotoxicity, the kidney damage is there. Half of the dialysis units are filled with the analgesic nephropathy, and especially in India, when we're diabetic capital of the world, in diabetes along with analgesic, and this is almost adding fuel to fire. Then these people keep landing to the dialysis units, and it gets more and more difficult with time. Then you have the gastric bleeds, all these people, and there are reasons of a massive gastric bleed in some patients, and this gets difficult. And even if you take strong painkillers, this may hit the higher centers, people get sedated, especially when taking narcotics. Now there is a WHO ladder already defined for analgesic ladder, we call it, and we start with the lighter drugs like lighter NSAIDs and all, then lighter opioids and stronger opioids, then intravascular pumps and spinal cord stimulators are there. Then we have analytic blocks or intrathecal pumps already there in line. So this is WHO pain pyramid. We have to go by the pyramid. If we say go slow and go high, step by step, that is to be followed. This is a safety thing. But when people keep straight away going to the stronger painkiller, and that's wrong. And narcotic is a very big issue world over. We know it now. Now these are some remedies. Now we keep putting talar braces. Remember, if there's a dorsal lumbar fracture, we don't put lumbar brace only. That's rather counterproductive. We should rather put a talar brace, which is dorsal lumbar brace, which goes from here to here and keep the spine in extension. If you put just a lumbar brace, it causes more flexion at the dorsal lumbar junction, and that's worsen the fracture. That's the worst thing to do. So that's why we always advise for a talar brace for dorsal lumbar fractures. But this is an age-old remedy from the Egyptian times and all. So we have to get out of this and get into newer era now. Fragility factor, remember, is a mechanical consequence of a biological disease, which is severe osteoporosis. So we're treating severe osteoporosis, and there are very, very good medications available these days. First of all, must take calcium, avoid osteoporosis, take sunlight, which is not possible, then take D3, and if it's already some osteoporosis, and a good diet and exercise is very, very helpful for the bone. But if still osteoporosis is there and there's a fracture, then we have all this anti-resorptive medicine which is there now, denosumab, or the we call it a bone forming medicine, which is the osteoblast promoters, which is the teriparatide. And we can always use the calcitonin nasal sprays which are available. The combination of these three can heal good number of good fractures in younger age patient with a good bone health. So we don't have to really do something surgical for them. Yes, one should really know how much you can give and how long one can give. As I told you, must give calcium and D3, we don't have to avoid on that. And teriparatide is started, which can go up to 24 months. That's the limit normally. We have to see whether if it increases, because there are some issues after 24 months. So we can give 4 times 6 months, or we can give one go 24 months. And then denosumab is already there, which is very, very good bisphosphonates, one of the bisphosphonates which is injectable. This is once in 6 month injection. That's the best bet out of this. So it is easy, twice a year you inject, and that's it's a done deal. And this can be given up to 10 years. So that's the beauty of the denosumab. Then you have bisphosphonates, which is like weekly or monthly. Everybody knows about it. They are very, very good, and in their own bet. That is good for the people who are not fractured yet. For normal health population, for good health, we can give bisphosphonate for osteoporosis. And then, as I said, oral calcium, vitamin D. They are the base, the brick and all, mortar. Now there are some people who are habitual osteoporotic fractures. You don't find a big reason, but yes, they keep fracturing and they keep coming back to us. It has happened with one lady. She has about 10 level fractured at different times, and she comes and she just requests one thing: doctor, please put cement in me. That's it. And because they get a good relief, it has proven itself over a period of time. That's the best thing. They are off medicine and they're back to normal life. So they have a fracture like in USA and all. People drive into the center, they get the cement filled, and they go back driving back. So there's a fill it and forget phenomena is there, which is a quick fix kind of a solution for these patients. There are patients who are in very, very big pain because of the osteoporotic fracture if it is non-healing, and there are complications to that also. We should really know about it. but if you do a good work on them, they go back to life and they get more normal. Just for my friends who are there, who are listening, and this is important, that X-ray alone is not enough. Look, this is the one, if you do an X-ray, this is the one which is fractured. But this is an old fracture which is semi-healed. This is the fracture which is causing pain to the patient. And this is the one which is going to complicate, and there is already retropulsion going on. Same way, this is the one which is fractured, which you, on X-ray wise, it should be absolutely normal what you see. Same way, this is the one which is X-ray wise fractured, but the pain is coming from here. So we really have to address. An MRI is always advised. Sometimes we do a stir sequences to know old and fresh fractures and treat the fresh fractures for sure. Old fractures doesn't take the priority. It can be taken if you think you can fill it. I have patients who is 1 year old fracture and 5 year old fracture. If you can, I have to fill 1 year old fracture, 1 month old fracture, the fresh fracture we call it. But we might need to do the cementing of the old fracture if it is painful, if there is a meroedema. So that is, these sequences are contrast MRIs, bone scans. They really prove that exactly how much is the activity in the fracture area. Is it really further collapsing? Is the meroedema or is healed now? If it is healed, we leave it alone. Bone marrow is another useful thing, is that we really have to rule out, are there any mats? Is it a kind of a metastatic fractures coming from the other zones, like comes from lung, breast, other places, prostate for that matter, or there is any pars fracture in such patients, or if by chance if there is any infection, like POTS one is a very common problem in India. One really come to know with all these scans and studies. Before you get into the body with the needle, we should really know what fracture are you dealing with. Is it traumatic one or osteoporotic one or infective one or metastatic one, and treat accordingly. Sometimes there is osteoma, which is a osteolytic cyst which is there, and that's a different subset of patients, and that can be dealt with the radiofrequency itself for pain. And if need be, one can put a drop or 2 drops of cement if it's a small cyst which needs some cementing. Otherwise, you don't need to cement these patients. Recent imaging is vital. Why? Because you just see, this is the fracture which patient had 20 days back, had an MRI, came to me for treatment. On the given day when I was about to kind of cement the patient, I got a fresh MRI, and look what is this. Because patient keep traveling from distances. When they travel from distances, they put load on the spine, and the spine fractures further on. And this is one, the fracture is there now, which needs a different kind of treatment, a different armatorium for cementing, because this is collapse now. This was simple vertebroplasty, put in needle, fill it. But this is, if you put in cement will leak from the crevices, like it is a crevice here, there is a dehiscence, bone dehiscence from all over. It's a burst fracture now. And there is a retropulse fragment with a open posterior cortex. This can get into the canal. So cement should never get into the canal, because the cord is going next to it. Just see this. You don't want that to happen. Yes, if there is a patient who needs some help and you don't do it in time, we have seen people coming. This is a young patient, by the way, and look at the collapse, total bone loss, no architecture. Obviously, the spine is whole bent. Remember, if the spine keeps bending like this, and there is a load on the next level also. So if there is an older fracture, you see multiple fractures coming one after the other, is typically load shifts to the next level, and especially at the dorsal lumbar junction. So in older age patient, you see multiple fractures like this. They keep coming, they don't treat it effectively, they don't understand the angulation problem, and because of the angulation problem, other levels take the load and the fractures. The surgeons are doing good job. They are doing implants and all, but then implant failures are known. This implant is broken at 2 spots here. You can imagine, you can see this is broken at 2 spots. It can't hold the bone now. The bone is falling back in anterior wedging is there, anterior column is collapsing. So we have to reinforce the anterior column. That is one you have to strengthen back. If you do strengthen back the anterior column, the posterior column is taken support by the facial joints and other posterior element is there, but anterior column has to be supported. That's why I try to fill cement in the anterior column, and that we'll see. Or sometime, in spite of best of surgery being done, there are some issues with that, and that is one of these patients who came to me. I put in a spinal cord stimulator for this patient. Now this patient, it's a true story. He is without a gentleman, just a diabetic, 64-year-old surd friend. He was almost like a friend, and he was diabetic and small alcoholism was there, and he had a very nice looking fracture and was to be treated conservatively. But if you don't leave your patient alone, because what you see is a good looking fracture can really worsen in a very short time. This was almost like in 3 months time this became totally flat. It's called a wedge fracture. You can say it's like a wedge. Anteriorly there is no height, millimeter only. And then we do a lot of big work there, like he had a D11 fracture, so we did a thoracolumbar incision and a lot of good work. And then 3 surgeons, they came in, neurosurgeon, orthopedic surgeon and abdominal surgeon. They did a very good titanium caging and implant, and this was there. And well, good job done. Patient was in hospital. He had few complications, like he had a hemothorax, then he had some problem with the oxygen saturation. He was put on oxygen, then he had a hypoproteinemia, then he was given some albumins and all, and then was discharged 2 weeks after the whole thing, and to be brought back dead 1 week after discharge. Now there are known complications of a big surgery, and including spine surgery, of a long-term hospitalization. And this is one of the patient who we really lost, and we feel bad about it even today. But he had a very big pulmonary embolism because of the DVT. Now this can happen in spite of all cares being taken. These things are known. We should respond to patient changing needs and times. These are times we don't have to wait for a big surgery. First, deteriorate the patient and they do a big surgery is not a great job. If you think the patient is going to deteriorate in due course of time, take up in time and do the needful. So we all have to be more responsible. What is percutaneous vertebroplasty? Friends, percutaneous vertebroplasty is an interventional technique in which surgical PMA cement or other cements are there now, is injected under local anesthesia via a wide bore needle into a fractured vertebral body under imaging guidance, providing increased bone strength, stability, instant pain relief. This is the best part. And then decrease analgesics, obviously patients off painkillers thereafter, and increase mobility. Patient starts back to work, in daily life even, with improved quality of life and early return to work. That's what you run. And early return to work is not only the patient, the whole family now is free to go to work, and that is important, especially in older age people. You need more and more caretaker, and smaller families are there, so not many people around. Reserves are very poor now. So the commonest indication for the vertebroplasty was senile osteoporotic fractures, then is a metastatic or MATS, then we have a hemangiomas, and then the other reasons. And even before spine surgery, we give it cementing in the body for strengthening, because the screws otherwise take out. And in a polytrauma setting, we have to fix the fracture, because otherwise other injuries, they are difficult to treat with the fracture spine along with this. And that is where it says the commonest reason is the osteoporotic one. Then we have hemangiomas, and this hemangiomas, neoplasms, and the other is definitely, I told you, the trauma ones. Now this is one of the patient. Now to give you an idea what we really do in these patients is, what is the vertebroplasty? If you are able to have a look at the screen now, can you see the screen, Momita? Now we just go transpedicular. We going from the pedicle here. We
Yes,
getting
sir,
it.
yes.
Yeah.
Screen is visible.
Can you? Is it visible to all? Yeah. Yes, dear. Is it visible to all? I'm just trying to know.
Yes, sir.
Okay.
It's visible to all.
Okay. So we get into vertebral body. So we just go like this. Just remove the pedicle, transpedicular, go into the vertebral body, and in the vertebral body we just inject cement inside, liquid cement, which hardens in about 5 minutes time. And it's such a good procedure, such an effective procedure. One should not leave it to chance that once it deteriorates or spoils, then we're going to handle it. No, let it be in time. Now this hemangioma, very painful hemangioma, there's a risk because there's no bone here. Risk of fracture, it was painful, just cement filled. By the way, the first vertebroplasty was done in 1984 in France for the same reason of aggressive hemangioma. That was the reason why it started. Thereafter, now people are doing it. That was an accidental thing, that somebody had a very painful hemangioma, there's no way to treat it. He just put in few drops of cement, and it proved itself, it became painless, and it has become a routine now. So what discovery has done, millions of patients of osteoporotic fracture benefited by that discovery, or somebody is good work. Dr. Derremand was there. Now this is, we have to understand, the lumbar fractures, they are best dealt with transpedicular or sometimes parapedicular. Transpedicular, we have to go with one needle like this. Parapedicular, if you have to go oblique, more oblique, go on contralateral side. And in a dorsal vertebra, we normally go costotransverse or parapedicular. get in the vertebral body, and we just cement in there. In cervical, I do cervical also. We just go anterolaterally. We put a needle inside, just like discography. You go from here because we just go and touch the bone. If you press on this, we just touch the bone, put a needle inside and cement it, and that's a smaller needle then, and just that's, and it needs a very small volume of cement. Don't need big cement volume. So this is the cross section. For everybody's understanding, this is a vertebral body cadaver specimen. I've cut it open after putting needle this, and this is where the needle is going. Transpedicular, going from outside the pedicle. It is this the pedicle now, and getting into the little body. This is the spongy bone mass, and you're going to inject your cement inside. Keep coming out. Stop injecting cement when you're close to posterior border, because you don't want cement to leak into the canal. And then just take the needle out, and that's it. We don't have to put cement thereafter. We don't have to put cement inside. The whole story of vertebroplasty is taking needle up to the anterior cortex, and second is injecting cement without any leakage in the canal. Cement may leak anteriorly, posteriorly, or sidewise, or even to the disc, no problem, but should not get into the spinal canal. That compromise is costly. People have done those mistakes. One has to be careful. It's a beautiful procedure for osteoporotic vertebral body fractures. Very, very helpful. Now, this is how the OT setup is, how the patients lied up. The CM is there. This is a fluoro-guided procedure, clear, period. We can use biplane fluoro, which is good. If not, then even single fluoro CM is good enough. We have to have a monitor view of it. Patient is normally in little extension, and that is how we have the whole kit and all contingencies available. When you go to a war, go well prepared. Vertebroplasty gives you only 5-10 minutes of cementing time. So one has to be fully prepared for that in that 5-10 minutes, what all is to be done, it has to be done with most efficiently thing. And this is like one can go through a single pedicle, cement inside, or one can go through two pedicles, both sides, and can cement, depending on. These days I go single pedicle mostly. If it's not good enough, then I put my second needle in. I don't put two needles in one go, and that is my little. This is the idea of it. One needle, if is going straight, if you obliquely it further, the needle will go across, so that will cement the whole vertebral body through and through. But if you are putting it more straightish, you might have to put two needle, and that increases the workload. If it is really like this needle, this patient, the needle is going in, is going across. Look at this. When I'm filling it, it's going to fill from front to back and right, left to right. So that's the whole idea of using needles in a more oblique fashion. But in dorsal vertebra, it cannot be so. It has to be more vertical, and you have always normally tend to put two needles inside. So in that I have a very special technique. I put a K-wire first, put my needle over the K-wire, then keep cementing it, keep coming out. This I presented in 2005 in 11th World Congress on Pain in Sydney. This was my topic, was on atraumatic fractures, cementing vertebroplasty, and not many people were doing in the world that time. So I was one of the first few who started this in traumatic fractures. This is the sliding wire in there. I'm putting my needle over the wire, just like you put in a cannulas and all, or other things over the wire, or central lines. Same thing I do it. Put a wire, put a needle over the wire, go to the anterior cortex, and keep cementing and keep coming out, and you see the global fill. You're left to right and right to left, and from front to back. Sometimes there are multiple fractures, or the patient is bad enough, patient is not taking care of the fractures and keep fracturing new fractures. You might have to put the all levels in one go, but keep extra needles, everything. It's a cheap treatment procedure. We use these metal needles which are there, which are bone biopsy needles. We use syringes to fill the cement in, and the cement is not very costly. Although there are kits available, automatic kits are available, which are very costly. In our country like India, where the patients are normally poor, we don't want to use these costly packets where it may cost ₹1,00,000 by itself. And our procedure is not more than ₹1,00,000 in normal circumstances in total. So why we can't waste money on the kit only? And we kind of make cement in the cold saline. We mix the cement as a liquid cement, and we inject through the syringe. I use 2 ml syringes with the manual pressure, inject inside, so you have a very good control on the syringes, and we fill the cement inside. So we keep filling cement from the front, keep taking needle out, and at the posterior cortex we kind of stop our filling in there. Or you should be very, very proficient that you fill from one side to the other side, or from front to back. That's called a global fill. But one has to be very careful there shouldn't be a drop of cement coming into the canal. That is the proficiency one has to understand. It's a quick fix treatment I mentioned. This gentleman is another friend's father, or you can call him a friend as well. He went to a Gurdwara in the morning, he slept there early morning in the dew, he fractured himself, look at the vertebral fracture, alcoholic diabetes, different thing. And then he came to me, same day in the evening, put a needle inside, cemented him. You see, not much of cement he required. He was pain free the very next day, and next week he was back to the Gurdwara. That's what you want. Otherwise, he was there for a few weeks in the bed and worsening of fracture. And I showed you the stories how it turns into. Another patient who had a fracture. Look at this white thing. What do you think this white thing is all about? This white thing is a fluid. There's no bone. I put my needle in there. I could aspirate some fluid just like I'm aspirating some blood sample or something. Just like, or a serum kind of thing. That way. So I could pull it out. I could fill the cement in there, and I give you the story of this patient. He was in ICU, and I was called that there's one gentleman who is in ICU. He is severely bronchospastic. He is on ventilator, and he is found to have a fracture of the spine. So then it is realized. Now let me tell you one more very important thing. Many of these old patients or bronchospastic patients who have a history of asthma, when they have a very painful syndrome in the upper back, there's a reflex spasm which is there, and they land in the hospital because of those reflex spasm without realizing that there is a cause is the pain. Now this was a patient like this. So I treated once he was off ventilator. I did a cementing on him, and he was kind of back to life. Although he is diabetic and blind by eye, and but still you have to treat these patients. And look at the patient who cannot walk otherwise for a reason, and he keeps falling. And if you don't treat his fracture spine, obviously he'll be paralyzed forever. Paraplegia will be there. There's another gentleman. He's only 59 age, and there is a kind of a fracture which is looking very rosy. He was put on medication, conservative treatment, perfectly fine. It's okay, welcome. But not taken a due care or lost the contact with the patient. Patient developed 6 level fractures in just about 2.5 or 3 months time. Not big hours, big time, but he was in very big pain. And on X-ray, this X-ray was showing this fracture as well beyond the one which was there earlier. So I doubted, so I got an MRI done. There was 6 level fracture. I cemented all 6 in one go in 2010. And I always keep saying vertebroplasty outweighs the conservative management in such patients. He was only 59, not to be treated. And I presented this in the Miami World Congress on Pain in 2012, because nobody did 6 level fractures by then. That was 3 was the upper limit. I did 6, and I presented. He was in pain. I could manage to do 6, so I did all 6, and people are very, very happy that okay, it is the start of the new era that he can do 6 levels also. Now people have done 7 also now. This was a patient in 2006 who had a polytrauma. She had a fractured humerus. When you were treating for fractured humerus, she showed back pain. We got an MRI. Look at the burst fracture. Everybody, it's a polytrauma setting. There's a burst fracture here. There's a burst fracture. There's a retropulsion which is there. Can you see the retropulsion there? And the cord is in danger. Look at this. So had to do a urgent cementing. Although she was osteoporotic, she was postmenopausal. She merits the osteoporosis treatment or vertebroplasty. So I did a cementing, and all these fragments, even the retropulse fragment which was free. A free fragment is like this one is glued in there. It's like putting a cement on the wall and putting a half brick on there. So this gets like putting a half brick back onto the cement. This fixes it itself, just like this. This was the brick and this is the cement. So cement holds this brick, so the spinal cord is free. This is the burst fracture. People are not doing it now. People are starting burst fractures also. It's a contraindication. Now it's changing. I got this patient for fracture spine from Satna for cementing. I got the study done on a given day. Look at the lesion here. Look at the lesion here. Now this is not osteoporotic fracture. This is a metastatic fracture. This patient had a CA. This is a complication of CA. Metastatic fracture. So obviously a bone scan, the other studies will prove it, a PET scan will prove it. And the spine is the commonest place to have mats. And that is where, because there are 33 vertebra and it really comes in there. So we have to treat very often the metastatic fractures. So it's like another metastatic fracture. There's a cord pressure coming up. So we have a technique of safety balloon which we kind of safeguard the cord and then cement inside. And the bone scan will prove the diagnosis or contrast and other things, and we do take a bone biopsy. If we are in doubt, biopsy is must. Yes, if patient is painful, like there's a dorsal fracture or and he had a CA lung, so we do an intrathecal neurolysis for pain treatment. That's a pain treatment. And just like another patient, a intrathecal neurolysis along with the vertebral body cementing. This is D3, by the way, D1, D2, D3 fracture in a CA lung patient or lumbar level, we do RF. And this patient, after the procedure, asked me to get a repeat CT scan done. I said, why? He said, my cancer is cured. So patient is taking cancer pain as a cancer and pain, it's a parallel. Once the pain is cured, patient thinks the cancer is cured. That's a beauty. Although he died after a few months, it was advanced CA. Now this is a new thing which is coming in. I am just sharing with my friends. It's a very, very new. We do a intraosseous radiofrequency ablation of the nerve or the denervation. So the pain is gone. But then you have to, or we do a RT also. RF and RT combined gives the best result in a metastatic fractures or metastatic bone disease. Now this is a new thing which is there, which is a balloon kyphoplasty, vertebroplasty. We go in there, put a cement inside, re-elevate. This is a vertebral augmentation. This is a true real specimen. Now there's the vesselplasty is a step further on. We leave cement inside the vessel and leave the vessel inside. It's a small balloon kind of thing which stays in there. This is what the kyphoplasty set is all about. And this is the balloon we are talking about. I'll show you some steps, quick steps. And this is like we put a wide bore needle inside, put a balloon in there, inflate with the inflation device with the dye, and this is how it will look like. The balloon gets inflated, elevates the fracture end plates, open up the fracture area, elevates the end plates, and then you do this filling. Look at this. This is the AP view, the side view. The bones were empty. You can't put this balloon in normal bone. It will take up the shape only in the empty bone. And that's where you want to first make a space and then put the cement in there. Look at the space made. Now you're putting cement in there. That's very, very common we do it. And that's what we want to see. A good filling and a good feeling on part of the patient and us together. And that really kind of elevate the, you can say the height. You see the angle part, which is saying the collapse is there. You reverse the collapse. Once you reverse the collapse, the pressure on the other vertebra goes down. And that is important to reverse the collapse. Sometimes one balloon is enough. Rarely you might have to put two balloons. Okay, fine. We can put two balloons. You decide it and accordingly plan it. Yes, there is a problem. This is the problem. I got a patient's wife bring the patient to me that he is addicted with the pan prag. And what was the problem? He had a fracture which was kind of operated with the they opened the laminectomy and all, but still there was a pain because the cord is tethered. Now this is bad. The bladder and bowel bladder functions gets compromised, and there's ongoing fracture activity and there's ongoing pressure on the cord. So we might have to cement these patients, but it's bad, very bad patient to kind of take up, and it's a hard luck on part of the patient. Another surgery was required. Remove this bone, put screws in there, but neither patient nor the surgeon wanted another surgery on this patient. Another such patient, 2-level fracture, cemented these 2 levels, 3rd level which was not looking fractured, look at the cement which it took up. So that was the next imminent fracture. So sometime we have to do imminent kind of things, vertebroplasty, which is preventive kind of thing. There are patients, like this is a patient which I just recently did, just very recently, 3 days back. This is the cord pressure which is there. Look at the fragment which is getting into the canal. All of you, look at this fragment which is getting into the canal, compromise there. The collapse which is there, the body is collapsed totally, and this is post-filling. This is the nicely filled vertebra now, and the patient is walking. Patient walked 2 days back, patient walked back home. And that is what the kyphoplasty balloons that open up the vertebra. Look at the open vertebra. This is the cementing in there. Cement is rock hard. This is harder than the routine cement what we see in our walls, house walls. Another patient who has been done a very good big surgery with screws and all. There is an empty bone one can see. And what we have to do in such patient is sometime we might have to intervene. This is the marrow edema. You can see the bone scan is proven the painful spot. We go inside, put balloon in there. Look, the balloon got inflated. Everybody. And now we lastly put the cement in there. And that is it. And look at the surgery which was done initially. The screws are put through this scar. And this is our needle point there. So it's almost no scar surgery. That's the beauty of it. In all dirty, failed kyphoplasties and all that. This is kyphoplasty even are known to fail. If you don't do it right, If I am the one or somebody else is not doing it right, just putting cement there, leaving all this open, patient will still be symptomatic. You put cement there, you don't do anything about it, patient will still be symptomatic. So I do a technique of epidural ballooning, which I presented in the World Congress in Jeju Island, 2000, South Korea, and 2016, and World Congress of Minimal Spine Surgery and Techniques. And that's what I presented, my balloon technique, whereby even the totally collapsed vertebra, like there's no bone, I make a bone in there, like cement bone now I can call it. There's no bone, you can see the disc and disc, no bone, zero bone, all bone pushed. I make a bone which can take the load now, and patients are back to life. She is 86-year age. So just 5-6 more slides and that will be it, and then we have question answer sessions. Now this is about the sacroplasty. Some people have sacral insufficiency fractures or aggressive hemangiomas. We put needle inside, take the patient to the CT room, do our cementing inside the CT room, and that is how we fill the cement in there, and then patient is fine, pain free thereafter. This is in the cervical vertebra. If this patient had a dorsal level fracture also, is a doctor. Dorsal level fracture and cervical also. I cemented dorsal as well as the cervical with a just a epidural needle, you can see. Go inside, put cement in there, and it's almost pain free. And this is a patient, very, very daring thing. He had a fall he had a CVA phenomena, he had a fall, he fractured his odontoid there, and that's where we had to put a needle in there and then put cement inside. This is transoral V2C2 cementing, and this is the patient. He came to my OPD later on, and just by the way, this collar is for safety sake. Yes, vertebral augmentation, we can make it safer for wider application, because by the way, these cases were not done earlier. When I've started doing, now people are following, they have started taking up, but it's very, very demanding on part of the people, and you should be very proficient when you take up a burst fracture or totally vertebral plana, we call it a total collapse fracture, or fracture without epidural balloon. We cannot do a big work in there, we have to have a safety balloon there. And I've done 6 level, I told you that time was a world record, now people have done 7 even. And there are patients who have a retropulsing fracture, which is may compress the cord. You have to safeguard the cord and cement them. Yes, you have to do it, you can do it safely and effectively, and there are countless blessings on part of these old people. Please remember, old people need more help, more support, because then obviously there's a very big load on the part of the society and there's nobody to help them. So as a humanity or human touch, we should go and serve them. Teaching is the best learning, I keep saying, and I do a lot of training courses, and I call doctors from all over the world and they take training with me. So I have about 15 people coming at a time. They do these live procedures. They get to see it, they get to know it, and unless they see it, how will they go back and do it? So thank you, my friends. Thank you, ClearNet. Thank you, friends, for your time. And this is, I keep telling, that I attended a World Congress in Montreal, and the logo was pain relief is a human right, and is proven by UN also now. And they say it's going to be very, very vital that all patients who are inside hospital, they have to have a pain relief. So we have pain scores already coming in the hospital settings as a 5th vital sign. And it's not for the older people we are talking, like osteoporosis in old age phenomena, postmenopausal. We do have to do it for our generations to come, because we want to leave this world a little pain free, and we want to keep it pain free as well as possible. So it's our moral obligation, it's our medical duty. Let's do our best to give best to our patient and society and make it a pain free India possible. Thank you so much, my friends. Thanks for your time. Thank you, Momita.
So much, sir. Thank you so much. Thank you so much for your comprehensive talk, and the presentation was really informative for all of us. Sir, we have received few questions from our participating doctors. So with all your permission, can I put them across?
Yeah, go ahead. Any number of questions. I like questions because you get more out of this talk, once you have more questions. Yeah. Please do. Go ahead.
Okay, so the first question we have received from Dr. Prachi: are there any specific fracture characteristic or patient factor that influence the choice between percutaneous and vertebroplasty and kyphoplasty?
Good question, very practical question. It seems that she's already into the doing of the vertebroplasty kyphoplasty, as interventional radiologist, interventional pain specialist, or somebody who is doing interventional technique. And this is one of the best treatment possible in a painful senile osteoporotic fracture. I don't delay. If I find there is a patient who has come to me with a fracture, it used to be norm that you wait for 6 weeks. If it doesn't heal, then do it. I've seen waiting for 6 weeks, many patients get worse. So you start counting the people who have a severe osteoporosis with the BMG study and all, and the bone mass is not there, the bone health is very poor. There's no point waiting and putting the patient in bed for about few weeks, because then there's a more bone loss. More they wait in the bed, there's more bone loss. So you want them to find and be active. Now, putting the difference between a vertebroplasty and kyphoplasty, if there is a height loss more than 50% of your vertebral body, that is the one which needs a balloon inside first, elevate the vertebral end plates, open up the vertebra, and which I aid with the extension of the spine when I'm doing my procedure and traction of the spine, and then make a space first and then fill cement in there. Because what happens is, if you don't have a space first, you start putting cement in there, cement may leak, and it may leak. That's the worst thing is if it leaks into the spinal canal. Suppose there is a posterior cortical dehiscence, posterior fracture, and you start putting cement in, the cement starts coming out into the canal, coming back into the canal. You cannot put more cement in there. Or sometimes cement may get into a vessel. Now those times, the intelligence thing is, stop for about 15 seconds or 30 seconds, because the cement inside the body is at 37 degree, and cement outside which you make in the bowel is at about 15 degree or so. It's a cold cement. The cement gets harder at the higher temperature, so inside body it gets very, very solid very soon, and outside is still in liquid state. So you can take more cement and inject inside. Now once that cement inside the body which was about to leak or leaking, it embolizes the vessel, or it fixes the crevasse, like there was a crevasse, it fills that crevasse. Now you can turn your needle inside. Keep your needle patent, by the way, with the trocar. Now you turn your needle in, start putting more cement in there. So that is something as a guide. Then when cement is leaking, what to do, number one. And second is, between a vertebroplasty and kyphoplasty, it is said vertebroplasty is as effective as kyphoplasty in good number of patients. But if there is a big collapse, there is a flexure, the sagittal imbalance, or there is a flexion of the part of the spine, the angulation is there, which will put load on the next levels, or there is a dorsal lumbar junction which is already in a flexion. So those are the areas where we tend to put in a kyphon first, balloon first, and then fill cement in there. Or you're already doubting the cement will leak as soon as you put in because of the bad fracture, like burst fracture and others. There you have to be very, very careful that you have to avoid leak. And when you put in a kyphon, you put a thicker cement. You don't put liquid cement or lighter cement or more. You start putting more viscous than just a liquidy cement. That's the adjustment you tend to do. So yes, it's important, it's good. But in our country, the problem with the kyphon balloon is costly affair. So not many people can afford, especially poor cannot afford. Yes, but it's very much in the CGHS, very much in the Mediclaim panel available. But definitely the balloon being costly, that is to be used judiciously in a patient who can afford, or the system which can afford, or the patient who really needs. You cannot do without, even if it's a poor patient. The balloon is an ideal one, or cannot do without a balloon, then you have to put in a balloon. But surely 50-60% of these cement patients who need balloon can be done without balloon. It's not absolute thing. You can choose to, and you can just put cement inside. It will definitely become pain free. All patients you take up for procedure, you have to treat the osteoporosis. Remember the basic cause, the basic disease, osteoporosis. Give an example. If somebody has got a diabetic abscess, you treat the abscess, but you have to treat the diabetes in any case. So that's how the osteoporosis is a medical disease which needs treatment. The osteoporosis or fracture is the surgical complication of that which you have to manage.
Thank you so much for answering, sir. So we are moving to the next question now. Okay, so this question we have received from Dr. Aditya. He wants to know what is the long-term durability of the vertebral augmentation achieved through percutaneous and vertebroplasty and kyphoplasty.
Well, once cement inside body, it is there lifelong. It is there. It is not. It is part of the body now. And by the way, that bone is the strongest bone of the body. The biggest bone mass which is there now is the, or the mass in a body is there in the, this is vertebra which you filled in. So that will never fracture again until unless you did a suboptimal filling. Then it might refracture. Otherwise, this is the strongest bone. It stays all life body, all life till death of the patient. So as far as longevity is concerned, this is a, like I told you, some lady came to me 10 fractures. Every time she comes with a new fracture, not with the older ones, that is already secured. It's like a secured one. Now you take up the next one. So the next one, it's like when you do a tooth problem, you do RCT at one, the other tooth gets the problem, then you do an RCT on the other one. So the first one is secured. So same situation, like we have 32 teeth, we have a 33 vertebra. So you secure one, that is secured forever until unless you did not do a good job. So as far as longevity of the procedure is concerned, it's a lifelong, pain-free for that level. Yes, other levels, I told you, must take care with the good treatment of osteoporosis and avoid fractures, avoid fall. That's another very important thing. People don't understand. Many times older people, they tend to fall. When they fall, they fracture. So you have to avoid fall. You have to do a good osteoporosis management, and it's a lifetime treatment. Once time sitting, feeling of this vertebral body is lifetime. You cannot go in that vertebral body again because it's a rock hard now. And it's a very effective treatment, by the way. Very effective. People who do it, they really know it, how useful it is. And by the way, it's instant relief, quick fix. You put needle inside, cement inside, within 10 minutes or it gets hardened, half an hour, patient walks back. That's the beauty. Whether he goes to the ward or he walks back to the ward or walks back to the home. So he is absolutely free thereafter. And mostly pain free except needle pain for for few days to come. That's it.
Okay, sir. So now we are moving to the last question of today's session. Okay.
I was expecting more questions because a very, very topic which concerns osteoporosis. I tell you, osteoporosis, older age problem, because more people are getting older, more people are getting osteoporotic, more people are getting fractures. So, but the realization is very poor that this back pain is because of osteoporotic fracture. So many times people come to us and we get a study done. X-ray is not always good enough. MRI, then you find there's a meroedema, there's a fracture. Like sometimes they have a pot spine, it's a different story. That's more of a younger patient. But in older patient, osteoporotic patient, more often they have fracture. It is said, if you do X-ray on the 60-year people, almost 25% will have fracture. If you do X-rays or MRIs of 80-year-old or older patient, 50% will have a spine fractures. You can imagine, many people don't complain, they just complain of back pain. So we really have to catch these patients who have a back pain, who had a fracture, they didn't know of it, and we didn't check it, we didn't take up, and then it's like we do a blood sugar for patient for a preoperative checkup or PSC, and we find if somebody is diabetic. Then patient was diabetic even before, is that we come to know now. Same thing happens with the painful fracture, back, that like I said, osteoporotic back pain, that you get a study done, you find somebody already has a fracture and we didn't realize it before we saw it. But the worst thing is, don't let it get into complications. Fracture is known. A complication fracture is very nasty because cord is there, and I've seen people with the paraplegia. Now I'll give you one example which is a lesson for everybody listening to me. That people, like somebody has fallen from tree or fallen from a height, and somebody has had a very severe back pain. Now this time you should bring the patient at the triage on a hard surface, like we call it a spine kind of a trolley. Not like I've seen people bringing in a chadar or in a bed sheet or putting in the lap and just bringing the patient here, and they flex the patient there, and this causes total collapse of the vertebral body and the cord gets compressed, patient gets paralyzed. Then patient was not paralyzed when patient fell. Patient gets paralyzed when patient is brought to us or tried during the triage time. So no, this should go to the society. People should know it. The triage of a fall in a spine patient or spine problem patient has to be brought in a straight, even a takat will do, anything, any fatta will do, anything will do. You don't have to have a trolley everywhere, but at least you have a straight surface, you can bring on that, and that's much safer than putting in a sheet or bringing in the lap. That is to be taken care of. Yeah.
Okay, sir. Thank you so much. Okay. So we are moving to the last question, sir. How can we optimize this question we have received from Dr. Aditya? How can we optimize the perioperative care and post-operative rehabilitation to maximize the benefits of percutaneous and vertebroplasty?
Good question, I think very practical question. Well, vertebroplasty is one part of the treatment. It's not the full treatment. Although, if you ask me frankly, if it is a fresh osteoporotic fracture, you put in a cement here, cement in there, then you just have to treat osteoporosis. Forget about the fracture part. That's number one. But many times we keep getting chronic fracture patients or a new fracture with an old fracture patients. So those people they already deconditioned. They already having problem, back pain. There is a mechanical pain which has come in because of the change in the shape of the spine, or facial arthropathy is there, and good number of patients do have a disc disease also along with this. So patient may have a facial arthropathy, patient may have a disc disease, patient may have SI syndrome, and patient does have now the osteoporotic pain along with the fracture which may be compressing the cord or the root. So this is a complicating, or canal stenosis. So you have to treat all of them. We take cognizance of all these factors and treat their fractures. But understanding is vital that once we are doing this mechanism, this treatment, that you have to treat patient as a whole, not just one vertebra and cement it. Patient as a whole has to be treated. If there is a comorbidity, must treat comorbidities and bring it to the maximum level. Definitely the spine rehab is vital, the exercise part is vital, physiotherapy is vital, nutritional support is vital, which I mentioned earlier also. That put together, that will maximize one part of the patient. But understanding is vital that if you treat a painful osteoporotic fracture, patient is really back to life, and that is what you want from these older people, our grannies and nannies and whatnot. And that's going to be older people. We want to give them quality of life. It's a moral duty, and I initially said it's a medical duty on our part, being doctors. So that's where it really gives good relief. Yes, you have to support from all around. Nutrition supplements are there, and if they are okay, then you can put them on exercise. The best part is, as soon as cement fracture, pain fracture, the patient gets pain free. Patient is mobile now. Patient is no more in the bed. A bed rest is counterproductive for such patients. And a painful fracture, you cannot ask them to move around, obviously, but must put a brace initially, which I mentioned you, till the fracture is healed or treated. If your cement is done well, your everything brace and every sport goes away, and patient is back to routine, and the family is back to routine. But yes, if you think patient has a falling problem or something, give it a sport, stick or walker, because of the other reason, not because of this fracture, because of other reasons, but must see to it that patient doesn't fall. So we keep telling people, put the lights on in the night, small bulb is there, so they're not walking in the dark, going to the water, and the bathroom should not be wet, they sleep in the bathroom, wet bathrooms. So those are smaller things, but they are equally vital, because in a study which is said, these are more important measures than just giving medicines to these patients.
Okay, sir. Thank you so much, sir. Thank you so much for answering all the queries of the doctors. And I would also like to thank all the participating doctors for your continuous participation at our platform. And thank you once again, sir, for your valuable time and being with us on our platform and sharing such a valuable insight. So, sir, with all your last comment, we can conclude the session here.
Well, I think probably more people know about it. More people, if they kind of help these patients, treat these patients, that's what we want from them. And that is what is really desired out of all these people. And please understand, if there's a patient who has got a fracture and who needs help, there is a very big help available, which is straightforward. Fill it and forget it. And they're back to, there is a very good treatment available. There is no merit in suffering. Pain is real and treatable. And if it comes to realization is there, if it is one of my family member and my older family member who has got a fractured spine, I will never wait for a big conservative management which may not be helping or may be counterproductive, and the assessment has to be done beforehand, and you come to know which patient is going to be better, which patient is going to be worsened accordingly. In younger patients, we do conservative as much as possible, but very close watch on the fracture. That's important. An X-ray will tell most of the time, but rarely we may need an MRI also. But yes, there is a very good modality. Please take help. Please do good to these patients, and one life to live, live it pain free, and live and let others live. That's what the message is. And I really wish all the best to all dear friends who are there, who are listening, learning. And this is a new technique which is not well versed, and it's good with that we're talking about it.
Thank you so much, sir. Have a good day and take care.
My pleasure. Okay, bye. Good night. Bye bye.
Good.
Bye.